slides.
Yeah.
Hello, this is Charlie Krasner. I'm here with Amy, Jessica, and Mike. And
How pretty.
yes,
Literally potpourri.
I got crazy with this design ideas on PowerPoint. It's just great. It makes your slides look great. And so that's half the fun of doing these talks. Anyways, first of all, you guys have any questions or any issues that have come up that you'd like to discuss? So that's for all ears.
Any cases?
Cases, the weather.
The weather.
Well, as we go along, if you have any questions. So this is more of a relaxed talk today. I wanted to go over some cases of community-acquired pneumonia, and basically how we make the diagnosis, and if you ever wondered like how to read an x-ray too, so make it a little bit more enjoyable. All right, so this is, let's see if I can do this. So I'm going to talk about community-acquired pneumonia. And community-acquired pneumonia, basically, as you know, it's pneumonia which is acquired outside the hospital in a healthy host. But most of the time, when we see them in the hospital, it's these patients have comorbidities. So it's very unusual to see a healthy person in the hospital with pneumonia. Actually, I'm presenting a healthy person as the next case. But usually it's because they have comorbidities, whether it's things like heart failure, diabetes, COPD, kidney problems, or stroke. So it's hospital-acquired, usually in a patient with multiple comorbidities who ends up in the hospital, who's not had any exposure to a healthcare system. So they're not like cancer patients or they're not dialysis patients. They're basically just people admitted with pneumonia. And it's important to why do we want to classify people as community-acquired pneumonia? Because the treatment of pneumonia, as you know, is empiric most of the time. You don't get results for 2 or 3 days, and so deciding if somebody's had healthcare exposure or whether or not they've had just community acquired is very important, because oftentimes the pathogens that we treat are very different. So when you're treating empirically, as most of the time we do, you really want to have an idea of what the most likely pathogens are. And so we'll be talking about that and x-ray findings, which may point you in the direction of what the pathogens are. All right, so we're going to talk, case one is a community-acquired pneumonia. And this is Joe Camel.
Joe Camel.
He allowed me to put his picture on for the talk. And Mr. Campbell is a 73-year-old patient. He presents to your primary care office 3-day history of productive cough, wheezing, fever, and confusion. And again, he's got comorbidities, history of COPD, diabetes, heart disease, and was recently treated for sinusitis with an azithromycin pack a few months prior. All right, so he comes in with cough, wheezing, fever, and confusion. And on exam, he has a temperature, 100.8. He's a little bit tachycardic. His pulse ox is a little bit low. And when you examine him, he looks short of breath. He's a little bit confused. He's coughing up goobers, and which he shows you very nicely. And he has, in the back, he has some wheezing and bronchi lung exam. So smoker, diabetic, comes in with fever, cough, confusion, and productive phlegm. All right. So question for the audience. As you consider all his presenting symptoms of pneumonia, you decide that the most likely diagnosis is either asthma, chronic bronchitis, nosocomial pneumonia, or healthcare-associated pneumonia, or community-acquired pneumonia. What would be your most likely choice and why? Anybody?
It's cancer too.
We have the peanut gallery over there.
Jesse or Joy or Kristen, any thoughts?
A chronic bronchitis or a pneumonia, community pneumonia.
And why would you pick between those two?
without a chest X-ray, listening to the chest, how far down the breath sounds are, and of what quality the breath sounds are.
Right. So I think that's a good call. The only thing is about chronic bronchitis, you shouldn't have a fever. Chronic bronchitis, usually they not have fever. So I think most likely you're going to be looking at a community-acquired pneumonia. Obviously, asthma, again, should not have a fever associated with it. But acute exacerbation of chronic bronchitis or community-acquired pneumonia are very good. So what test would you order next for Joe?
The chest X-ray.
All right, you can go home now. Right? According to the latest American Thoracic Society community-acquired pneumonia guidelines, all patients with suspected community-acquired pneumonia should receive which test to establish the diagnosis? Chest X-ray, blood cultures, blood gases, sputum cultures, or Legionella and pneumococcal urinary antigen. So, as you said, it's chest X-ray. To make the diagnosis of pneumonia, you really need a chest X-ray. The other stuff would be nice, but doesn't help you make the diagnosis of pneumonia. So, clinical production of sputum, again, suggests a bacterial infection and the fever and the bronchial exam. So, you've made the diagnosis now of community-acquired pneumonia. Very good. All right, so for fun, I'll show you X-rays. I'm sure some of you know how to read X-rays, some of you don't see much. So this is a normal chest X-ray. And we're going to compare, we'll get some other X-rays just to compare it to what a normal one looks like. So in the middle, I don't know if you, oh, sorry, go back.
Oh, you're trying to touch on the screen?
Yeah.
Okay, go ahead.
Oh, cool. So this is the heart, this right there, and then you have the spine behind it, and all these things here are the ribs, and the diaphragm on the bottom. So the rest of this are lungs. So the left lung, the right lung, and everything is basically black, except when you have the ribs and the scapula. So this is a normal lung. And the lungs are broken up into lobes. So like in anatomy class, the right lung has 3 lobes and the left lung has 2 lobes. And you've all heard of people saying you have a lobar pneumonia. Okay, so clear X-ray down here is the gastric bubble, the diaphragms, the heart, the spine, the ribs. But this is a clear X-ray, normal chest X-ray, no pneumonia. And so this is just an example of the right side of the heart. So the right side of the lung. So the right lung is, you can see here, is made up of 3 lobes. Here on the right upper lobe, and then you have the on the lateral view. So looking straight on the lateral view, the whole upper half of the right lung is the right upper lobe. In the middle, you can see over here is the right middle lobe. So it's sort of like a triangle between the right upper and the right lower. And in the front, it looks, you see it straight on. Okay, so you have the right upper, taking up the upper half of the right lung. And then the bottom half of the lung is divided into a right middle lobe, which laterally looks like triangle, looks like straight on is right middle, or you have the lower lobe. So you can see right upper, these are all lateral views, right middle and right lower lobe. And so when you have a lobar pneumonia, basically you have a infection which is basically localized to one of those lobes. So instead of saying, oh, I have a lobar pneumonia, you can be saying right upper lobe, right middle lobe, or right lower lobe pneumonia. Okay, so these lobar pneumonias are typical of what we call typical bacteria, Klebsiella, strep pneumo. And when we see a lobar pneumonia, oftentimes we know we're dealing with a standard bacterial, typical bacterial pneumonia, like Klebsiella or strep pneumonia. So the left side is also very similar, the left upper and the left lower. Okay, so we'll refer back to this chart. And so next X-ray. All right, so this is not our patient's X-ray, but this gives you a better idea. So on the left side over here, I haven't shown you the anatomy of the left side, but this is a lobar consolidation. This is localized to the left upper lobe. There's a left lower lobe, but we can tell it's left upper because it's the upper side, and it's not touching the diaphragm, the heart, the edge of the heart, and it's not touching the diaphragm. So this is a lobar pneumonia, so we don't have a lateral on this, but a typical lobar pneumonia. If you contrast it on the left side, you have patchy infiltrates throughout. It's not localized to one lobe of the lungs, not the right middle. It's bilateral, there's patchy infiltration, also cavities. So the left side I would call a typical lobar pneumonia. In the right setting, I'd say it's probably like a pneumococcal or Klebsiella. On this side, this is a very atypical presentation. This doesn't look like a lobar pneumonia, so I'd be thinking of other things like viral, mycoplasma, atypical infections, even a MRSA infection, something that doesn't restrict itself to the lungs. And so when you see a guy like Joe Camel who's coughing, and then you look at his x-ray, you definitely want to see what pattern you see on the x-ray. All right, so this is Joe's chest x-ray. Question, true or false? Joe's chest x-ray shows a right upper lobe pneumonia. Okay, so this is the lateral, and this is the front on. And so, what, anyone want to see what they see? Say what they see on this. All right. So remember, if you look on the lateral, the lung is, where's that? Yeah, so you go down here, you have the right upper, the right middle, and right lower. All right, so actually, right upper, right middle is the triangle here, and this down here is the right lower. So we can see here, right here is the line between the right lower and the right middle. So this is the right middle, this is the right lower. And it's touching the diaphragm, okay? So if we go back, we see it's touching the diaphragm, and we see it's what it looks like the right lower. So we go back, so right here, we have a right lower lobe infiltrate. So it's down here, it's touching the diaphragm. It's not filling completely the lobar, the right lower lobe, but this is a typical right lower lobe consolidation. So again, we see that it's right here. This is the right middle. The right lower is all over here. It's touching the diaphragm. So when you look right on it, you can't see the diaphragm because you're full of fluid and pus. So the diaphragm is very obscured over here. So you know it's touching the diaphragm, and you know it's in the lobe. So I would call this a right lower lobe consolidation or pneumonia. Okay, it's not like this X-ray, which is crazy looking. It's good. This is a lobar. This is a lobar pneumonia. So you got a guy who's a smoker. He coughs up. He's wheezing. He's got rhonchi. He's got temperature. He's got gross sputum, and now he has a lobar consolidation. Again, it's really staying in the lobe. It's not going everywhere. It's just there. So again, you think of a typical bacterial infection. All right, so gives you a good idea that what you're probably dealing with. And so if we look at the next question, the most common cause of hospitalized, not outpatient, cases of community-acquired pneumonia, is it E. coli? Is it Klebsiella? Is it mycoplasma? Is it RSV, pneumococcus, or MRSA? Any thoughts?
Strep pneumo?
Yes. It's always strep pneumo until proven otherwise. And so, but I can tell you, even if it's not strep pneumo, you're probably dealing with like a Klebsiella or Haemophilus. It's a lobar consolidation, okay? MRSA is horrible cavities. RSV is diffuse infiltrates. E. coli doesn't cause community-acquired pneumonia. It's more of a healthcare associated. So I would guarantee this. I mean, I'd say this is a typical community-acquired pneumonia, most likely strep, possibly Klebsiella or H. flu, and I would direct my therapy towards that. Okay, so x-rays could be really helpful in terms of coming up with the diagnosis. And this is, okay, strep pneumo is always the answer. It's strep pneumo until proven otherwise. From mild to severe case, it's number one. And what is the arrow pointing to? This is a gram stain that I like to look at. What are you seeing on that gram stain? Tell me two things you're seeing about where the arrow is pointing.
Gram positive.
Yes, and what else? What's around it?
It's encapsulated.
Yeah, so you see the clearing around it. So pneumococcus has capsules. Remember, that's why when you vaccinate them with a Prevnar or Pneumovax, you're vaccinated against the capsule. So the capsule is, it's like a clear space around. So every one of these, you can see a clearing around it. And you also see that they're pointed like little sort of bullets towards each other, like over here. So this is classic pneumococcal findings. First of all, these are white cells. You want them pink like this to tell you that the slide's been done properly. But these are classic pneumococcus facing each other with a clearing around it. And you can see the capsules everywhere. So this is, if you're able to get a sputum on a guy's culture, or you get a report from your micro lab. This is encapsulated diplococci, which is pneumococcus. And again, very consistent with Joe Camel's presentation with coughing, phlegm, fever, bronchi, and a lobar consolidation on his x-ray. And it's nice, all you see is, you don't see epithelial cells suggesting it's not spit, and you don't see like all different type of organisms to say it's not a good sample. So a good gram stain can really point you in the direction. So other common causes of community-acquired pneumonia. One is, as I said, typical. Typical means that they present like Joe Camel. They have respiratory complaints. They don't have extra pulmonary complaints like diarrhea and stuff like that. They complain. They say, I'm coughing, I have a fever, I got phlegm. And on the chest x-ray, you see lobar consolidation. And when you look at the gram stain, you can see these organisms, either Moraxella, Haemophilus, or a strep pneumo. So I'd say this is a typical cat infection. The term atypical usually is not with a lobar infiltrate. They usually have patchy infiltrates. And because remember, bacteria, when you do gram stains, they're picked up by the cell wall. Things like mycoplasma and chlamydia don't have cell walls, so you don't see them on the gram stain. So you have a gram stain with a lot of bacteria, a lot of white cells, but no bacteria seen. You may point you in the direction of an atypical infection, like a viral, chlamydia, mycoplasma. Legionella is gram negative, but it's intracellular, so it doesn't come up in the gram stain. So typical means typical presentation, lobar consolidation on chest x-rays, purulent sputum, and typical bacteria. Atypical, oftentimes extra pulmonary complaints, maybe ear, rash, pharyngitis, etc. Plus, gram stains are negative and x-rays are not typical lobar consolidations. Again, this is a picture that shows causes of pneumonia in different age categories. And yellow is strep pneumo. So even in the young people, strep pneumo is not uncommon, but it gets particularly common as you get older. Mycoplasma is also very common. I think it's more common than strep pneumo in young people. It's usually the person at the back of the hallway, the lecture hall, can't stop coughing and has 102 degrees. So that's more typical of mycoplasma. And then you have Legionnaires. We don't have that much Legionnaires here, and chlamydia. But again, whenever you're treating somebody from pneumonia, unless you already know the cause of the infection, you always want to cover strep pneumo. And so just talk about review antibiotic therapy for community-acquired pneumonia. You always want to cover the possibility of strep pneumo. And as I said, beta-lactam antibiotics like penicillin and cephalosporins only work against bacteria that have cell walls. So penicillin and cephalosporins are great against strep pneumo, Haemophilus, Moraxella, but they don't have activity against atypicals, where you need other mechanisms to knock off the bacteria. For example, the quinolones are DNA gyrases inhibition, and other ones are ribosomal inhibitors, etc. So penicillin works great against strep, cephalosporins. The macrolides have been so overused that there is some resistance against pneumococcus. And unless you're sure that it's not pneumococcal pneumonia, you're probably going to add something for atypical, for pneumococcal coverage. Like when you put somebody when you hospitalize somebody, either like Rocephin and Unison for the pneumococcus, and then you add the macrolides for the atypical coverage, but you won't hospitalize somebody, just give them azithromycin for pneumonia. And the quinolones work against the DNA, and so they're effective for all types. And doxycycline has some activity against pneumococcus, but again, it has atypical coverage. Okay. Yeah. All right, so this is a case I just saw a week ago in the hospital. This is a 25-year-old, otherwise very healthy young lady. She was seen a week early in urgent care, came with myalgias, headache, fever, and the flu season was still going on, so she tested positive for influenza. I was surprised that, I wouldn't normally give a healthy 25-year-old person Tamiflu, but she was given Tamiflu anyways. Usually Tamiflu is expensive and toxic, so usually try to save it for patients who have more comorbidities and more likely to end up in the hospital. Anyway, she was given Tamiflu, but she continued to have a cough and started developing some chest pain. She was feeling worse despite the Tamiflu and had a fever. First she started feeling bad, then she just started having this hacking cough and left-sided pleurisy. So when she coughed, she had pain in her chest. She had fever and rhonchi and exam, and in the emergency room, she looked ill, and she had sputum and x-rays obtained, and she was admitted to the hospital. All right, so woman getting over the flu started feeling worse with hacking flu, and she had not had a flu shot, I should have had. And this is her chest x-ray. It's not the most dramatic x-ray, but you can see down here, there's simply something going on here. But there's also some changes over here. And there may be some changes up here and over here. So this is not a classic lobar consolidation. She was having some pleurisy on the left side, so you're wondering about what may be going on there. And so they did a CAT scan of her chest. And these are two levels through her chest. This is the left side of her lungs. And this is a 25-year-old girl. She should have healthy lungs. She's got big cavities. This is just one of many views. She has multiple cavities on her chest x-ray. So this is a necrotizing process. Regular bacteria like pneumococcus, H. flu, Klebsiella do not cause these problems. So this is a nasty necrotizing process. And
How sick was she?
she wasn't in the ICU when she went back.
She wasn't?
I mean, she's 20,
Yeah.
25, nothing gets them sick. And over here, you can see over here on this side, these are her ribs and her pleura. But and over here, again, you see it down further, it still looks good. But here we see this fluid collection, and you can even see some enhancement of the lining of the pleura. So this looks like we call loculated effusion. So she has fluid, and it's sort of pasted in there. So she had these large cavities, and then she had this large pleural effusion. So there was a pleural process going on. So this is a necrotizing pneumonia, sick girl, post-influenza. And this was her sputum. What is the likely cause of this young lady's pneumonia?
Staph.
How can you say it's staph? You see?
They look like gram-positive cocci in clusters.
Yeah,
And
exactly.
classical teaching is post-influenza pneumonia could be staph.
Yes. Very good. So she read the textbooks. So her x-ray actually looked better before she came in. I mean, these are what happened. She had it, this fluid is like very thick and has to come out. It's basically pus. So the surgeon had to take her to the operating room. And you can see this thing here is these are chest tubes to help drain the pus out. So they open her up, they wash it out, and then they put these drains in to allow it to continue to drain. And there's actually some air here in the lung tissue. So these are like basically, if you can imagine two garden hoses in your chest, it would probably hurt like hell. I'm sure it does. So, but this is what you have to get. This stuff is so thick and gelatinous, it just has to come out, and it has to be drained. So she grew up MRSA and was treated with vancomycin, and she went home on, it was susceptible to clindamycin, so we sent her home on clindamycin to complete her treatment for a few weeks. And then she'll be seen in the clinic in a week or two with follow-up chest x-rays and make sure she's doing well. All right, so this is again, a community-acquired pneumonia, MRSA, in a healthy young lady. Not typically seen in young people, but it is known for post-influenza complications. So get your flu shot. All right, so these are some sort of pointers that I use. If you got a young, healthy person, mild disease, coughing, febrile, they're not bringing up sputum, it's almost certainly an atypical pneumonia. So like mycoplasma pneumonia or chlamydia pneumonia, very, very fine. And you could probably just, give them like a Z-Pack. It's not great for pneumococcus, but unless they're really sick, it'd be unlikely to be pneumococcus. But if they're really severe, then you worry about pneumococcus. And if you're treated as an outpatient, you may add like amoxicillin to the Z-Pack. And, even consider MRSA as a complicated pneumonia when you get your chest X-ray. If they're smokers, just like Joe Camel, think pneumococcus, H. flu, Moraxella as the causes of acute exacerbation of chronic bronchitis as well as pneumonia. Depending on how sick they are, you could either treat them with like a augmentin or a similar drug. All right. Some suggested community-acquired pneumonia regimen is not set in stone. Healthy outpatient, no antibiotic use. Think about Z-Pak or doxycycline. Basically a healthy person, not in the hospital. Outpatient, mild to moderate disease, prior Z-Pak. You may be worried about some resistant strep pneumo. So levofloxacin as a generic for how many days?
5 days.
No more than 5 days, yes. I just saw somebody getting a prescription for 10 days. And I was not happy with that. And then for inpatient, again, inpatient wards, you definitely, if somebody's sick enough to be in the hospital, you need to cover pneumococcus empirically. So either ceftriaxone or unison for that coverage, and then atypical coverage, either IV azithromycin, IV or oral doxycycline. And then you can, based on culture results, or you're not sure of the results, transition to oral levofloxacin. If somebody's sick enough to be in the ICU, there's 2 reasons they're going to be in the ICU. One, they just may have such bad comorbidities. You know, they're basically, a COPD is basically barely functioning. And something like a pneumococcal pneumonia pushes them over, and then it's still pneumococcus. But if you see cavities on the chest X-ray, which is not a common finding for someone standard, you want to think about adding vancomycin for the possibility of MRSA on top of this. So Rocephin, azithro plus vanco. And then you may have somebody on the right treatment, but empyemas are a common complication. So if somebody you think has pneumococcal pneumonia, they're doing good, and after 2 or 3 days they're getting worse, don't go vancomycin. Get an X-ray because they can develop exudative effusion empyema that needs to be drained. You don't need to change the antibiotics. So
One of the things that we'll do for outpatient mild to moderate infection with comorbidities when they've had the Z-Pak prior, if we'll do amoxicillin, or with or without the Z-Pak prior, we'll do amoxicillin plus atypical coverage. So high dose amoxicillin, 2 grams PO twice a day, plus the atypical, so doxy or azithro. We'll do that. We prefer that over Levaquin a lot of times, but the duration would be very similar, 5 days or less in some cases.
the advantage of doxy over azithro for atypical coverage is that doxy has some activity against preventing C. diff, and azithro doesn't. So doxy is a good choice for atypical coverage. And we try to encourage people to use it orally in the hospital.
I remember that case. We had a case where Jeff and I were with you. Patient had strep pneumonia. And we came back, Jess and I were looking at it, all of a sudden the right side, we could see nothing. And we were going, what is that? And that was when the patient got an empyema.
Yes, just amazing. Don't go vancomycin and get the x-ray and think about empyema. All right, let's see who's been listening. This is the 62-year-old smoker with chronic bronchitis, comes in with fever, cough, productive green phlegm, and shortness of breath. Sounds like Joe Camel. What is the pneumonia pattern on chest x-ray?
Lobular.
Very good. So it's actually, we haven't talked about the left side, but you can see how the left side is actually just 2 lobes. So it goes down here, and this is the left upper lobe, and this is the left lower lobe. So this is a lobar consolidation. And you know, it doesn't break that line there. MRSA, staph, no bad bugs, Pseudomonas, they'll just eat away at this thing. But Klebsiella, pneumococcus just doesn't do that. Okay, so then you can see it over here. So this is the front view, but this is a left upper lobe pneumonia, which typical pattern, typical presentation. So what's the most likely cause in this patient?
Strep pneumo.
Yes, very good. And again, you're going to be treating strep pneumo like Rocephin or Unison, but you're also going to cover Klebsiella Haemophilus, which will be treated very good. And empiric treatment in hospital, what would you do? You admitted this patient to the hospital.
we would either do unison azithro if they were admitted to a floor, we'd err on the ceftriaxone azithro side if they were admitted to ICU.
And you're doing the azithro primarily because you have to.
Historically, you have to. Yes,
Yeah.
yes. But, yeah.
You say, why are we treating atypicals if we know it's pneumococcus? But there were some studies a few years ago suggesting that azithro may improve the outcome of pneumococcus, maybe because it has anti-inflammatory activities. It sort of attenuates the sepsis, but that's questionable. And what would you use if you was penicillin allergic?
I'd ask him what his allergy was.
Yeah. Very good. My mommy told me we had an uncle who was back in the old country was allergic to penicillin. All right. Anyways, so now you know the terms, and if you do look at X-rays, you can see what they're talking about. You know, if it's a lobar pneumonia in a smoker, just because he's in the ICU doesn't mean he needs vancomycin. Okay, it's usually the typical bacteria. Just patient's always got a lot of comorbidities. So, all right.
I have a case that I forgot about until just now. It's not a pneumonia case. It was a gentleman, I believe it was a gentleman with a pacemaker pocket infection. No blood cultures were not positive. The pocket, they swabbed the purulence coming out of the pocket. It showed Staph aureus. This is at our facility we're now, and they did a PBB2A for me that was negative. So I had them de-escalate vanco to cefazolin. And then today, I got a fax from another facility saying that they cultured the exact same pocket and it's MRSA. When I look at the actual sensitivities, it's the MICs, it's less than or equal to, so on the amoxicillin and Cef, but resistant to the oxacillin. So it's labeled MRSA. Have you seen that before?
You should report that case.
Yeah.
That doesn't make sense.
It doesn't. And so we're still waiting on our final susceptibility patterns here off the microscan. But I was tempted to have them run it on the PCR machine to see if
That is interesting.
we're erring on
Did you have oxacillin resistant here too?
it's not up yet.
Oh,
So it should be up later today.
unless it's some kind of mixed thing.
But
Yeah.
it says
Yeah.
advanced.
Yeah, well, it says MICU is less than or equal to, but resistant because they change S to
Oh,
R.
yeah, that did change.
But the
that.
pacer has to come out.
The pacer came out already.
All right.
Yeah. There's just,
All right.
That is weird.
Stump to
we're
stump.
covering for, okay. No additional guidance for that. Thank you.
Any questions or comments? All right. Thank you all.
Well, my question is, how do you know when to test for Legionella? Legionnaires.
A lot of people would say it's part of your routine presentation, but you know, if you have I would be concerned about Legionella. You know, there's some things that will tip you off. You know, have they been on the East Coast, in Pittsburgh, and places like that? But two, when they have a lot of things that don't fit, you know, like whenever I've seen Legionella, you know, like Joe Camel, he's coughing, he's short of breath, he's complaining of respiratory. The interesting things about Legionnaires is that they oftentimes don't even complain, they don't even know they have a lung infection. They complain about diarrhea, headache, confusion. And we actually had a patient about 2 years ago. He went to the emergency room and he was very upset because he was told he had pneumonia when that wasn't his complaints. Everything else was bothering him. So Legionnaire should, anytime you hear extra pulmonary complaints, think about Legionnaire disease. Low phosphate, electrolyte abnormalities, elevated protein, proteinuria. And then you can just order a Legionella antigen, can be helpful. And also, the X-ray, if the X-ray isn't nice and lobar-ish, you think about Legionnaires. But it's just a constellation of lab abnormalities and extrapulmonary complaints.
They can often have high temps too, a pulse temperature disparity.
Yeah, sometimes, yeah, the temperature, the pulse is not as fast as the temperatures, yeah. And so it was really interesting. All the patients I've seen, you know, they're always surprised to be told they have pneumonia. So the doctor said I have pneumonia, but that wasn't my complaint. So anything that doesn't fit with a typical presentation, you may want to tip off to Legionnaires. And, you know, any of the levofloxacin or azithromycin or doxy has pretty good activity against Legionnaire's disease. And probably the best test is just to order urinary antigen.
since I've been retired, have we had a Legionnaires case that was originated here? No.
We're probably missing it though.
Yeah.
Not that we know of.
That's
I
what I'm saying.
don't know.
I don't know if we have
Yeah, that's a good
anything to add.
question, but
I just think the CDC recommendation is, and for NHSN, they want you to do a urine antigen and a respiratory culture for Legionella. And the respiratory culture for most places is probably a send out to the state
Yes.
lab. So
does that recommend everybody with pneumonia being admitted?
no, just if you suspect.
Yeah. So, like if it doesn't make sense, then you just start thinking about the weird stuff like the mycoplasma, serology, or chlamydia, pseudocytosis, Legionnaires, and so then you should order that. If it's not a typical presentation and it's not obvious, then get it. That's a good question. Thank you.
We hardly ever test for it.
So yeah, we don't actually know, I guess,
Yeah.
this year or not.
It's big on the East Coast, though, right?
Yeah,
And
picture you, that's the first thing,
and
Legionella.
the VA is fixated on the national, so they have committee hundreds of hours. I don't know if Beth's here, but hundreds of hours of talking about Legionnaire's disease. They have to take all the water pipes out. It's like,
Oh, I know.
like get a life.
Well, they actually had an outbreak at was it in Phoenix? At a nursing home, VA nursing home or somewhere. I think, I don't see Beth on there, but Carrie's on here, right? Isn't that her?
Yes, Carrie. All right, thank you all. Bye.
Thank you.
Thank you.